This works better when I turn off the mute. Good morning, everyone. Thanks for joining us for Grand Rounds here in February. We've got a great lineup this month. This morning, we have updates in obstructive sleep apnea. The next 2 weeks after this, we have Dr. Alan Brett joining us from the Rocky Mountain VA on updates in outpatient medicine for the past year. But again, this morning, it's updates in obstructive sleep apnea, and we're really excited to have Dr. Jessica Camacho join us here. Dr. Camacho did undergrad as well as medical school at the University of Arizona. Went to Beth Israel for residency, and then fellowship was here at CU. Dr. Camacho is a hospitalist turned sleep medicine clinician, is director of education here for sleep medicine, as well as the program director for the sleep medicine fellowship. In terms of questions, please type questions in the chat as we go. We'll hold Q&A for the end. And if you're in the room and you have a question at the end, I'll be walking around with a microphone. So, Dr. Camacho, thank you.
All right. Thank you, everyone. Can you hear me okay? Okay. I'm honored to be speaking today, and we're going to talk about updates in obstructive sleep apnea for 2026. And I'm happy to say there are a lot this year. I have no conflicts of interest. By the end of the talk, I'd like us to be able to compare and contrast various methods of sleep apnea testing, review positive airway pressure as first-line therapy for sleep apnea, broadly characterize PAP alternatives, and then recognize the emerging diagnostic and therapeutic advances in the care of patients with OSA, including some newer surgical techniques, neurostimulation, and pharmacotherapy. We'll start with a little bit of background. First of all, obstructive sleep apnea, it's characterized by repetitive collapse of the upper airway during sleep, leading to sleep fragmentation, hypoxemia, and increased sympathetic tone. Symptoms usually include snoring, daytime sleepiness, witnessed apneas, gasping or choking, and sleep disruption. It affects nearly 30 million Americans and approximately 34% of middle-aged men and 17% of middle-aged women. And it costs society billions of dollars in loss of productivity and healthcare utilization each year. OSA is not only associated with significant symptom burden, but also has several strongly associated adverse health outcomes, most of which are cardiovascular. So things like hypertension, AFib, heart failure, coronary artery disease, pulmonary hypertension, stroke, and even early mortality in those with severe OSA. More recently, we're hearing more and more about cognitive impairment, which is also associated with sleep apnea in patients with moderate to severe cases. How does this happen? In OSA, we believe repeated episodes of hypoxia and sympathetic activation lead to elevated blood pressure, oxidative stress, inflammation, and hypercoagulability. And in addition, large intrathoracic pressure swings during these events pose mechanical stress on the heart and great vessels. So on a macro level, OSA essentially works by repetitively interrupting sleep and sleep quality and firing off that sympathetic tone over and over again in a vicious cycle throughout the night. Despite all of these health risks, OSA remains widely underdiagnosed, with about 80 to 90% of cases going undetected, which is pretty substantial. So how can we identify our patients with OSA? They may present with the symptoms that we've talked about. They may simply have comorbidities that put them at higher risk. The American Heart Association, for example, specifically recommends screening patients with resistant hypertension, heart failure with nocturnal symptoms, and recurrent AFib in the absence of symptoms in those cases. Other things might be physical exam findings like obesity, high blood pressure, increased neck circumference, and oropharyngeal crowding by the Mallampati scale, with class 3 and 4 being at most risk. The Stop Bang questionnaire continues to be our most helpful screening tool for sleep apnea. Nothing new has come along in this area. It's about 85% sensitive. Scores of 3 or higher are 70% predictive of OSA and warrant further testing. And it's important to keep in mind that the Stop Bang performs best in obese men and does not perform as well in women, and especially our postmenopausal female patients. So something to keep in mind. Those patients might present with more nonspecific symptoms like generalized fatigue or insomnia. Now, once we are suspicious for sleep apnea, how do we diagnose it? Yeah, the Epworth alone is not as good. The sensitivity is lower. So the diagnosis of OSA begins with a calculation of the AHI, or apnea-hypopnea index, in which apneas reflect near complete obstructed airflow, and hypopneas reflect a partial obstruction. We add all of those events up, divide by the number of hours of sleep, and we get an index of events per hour. 5 to 15 is mild, 15 to 30 is moderate, and 30 or higher is severe. Once we know the AHI, we can reconcile that with the patient's clinical presentation to make our diagnosis. So by definition, from the American Academy of Sleep Medicine, sleep apnea is when the AHI is above 5, greater than or equal to 5, and is accompanied by either comorbid symptoms or conditions, or just above or equal to 15 without those, with or without those. In the figure on the right, I wanted to highlight that the AHI can be difficult to identify on a sleep study report. And the 4% AHI is the most widely accepted under most health insurers. It means that the oxygen level has to drop 4 points for us to score the event. So it's a bit stricter guidelines. And as you can see in this table from one of our own sleep study reports here, it's buried in the middle of the table. I wanted to highlight it for you. When it comes to sleep apnea diagnosis, we have a variety of testing options, which is wonderful. To calculate the AHI, we are going to begin by discussing the two main branch points, those being the in-laboratory sleep studies and the home sleep studies. The in-laboratory polysomnogram remains the gold standard by which we test all other treatment modalities, and it gives us 21 channels of information. It provides a highly accurate AHI. It's supervised by a trained technician for the full night. It can diagnose a wide variety of sleep disorders as well, not just sleep apnea. And the main downsides are that the patient does have to come in and spend the night, which can be difficult for them. And it does cost more, around $3,000 plus several more $1,000s for facility fees. There are 3 types. We've got the diagnostic polysomnogram, where the patient spends the whole night being observed. We've got the split night study where the first part of the night is observation and the second part of the night is CPAP treatment. And then the titration study, which is a full night on CPAP. Then we have more commonly used nowadays, home sleep tests. So home sleep tests have a lot of advantages. They're pretty simple, easy to use, and readily available, and they're a lot less expensive. The figure on the left shows you what they look like. This is our traditional flow-based home sleep study. It measures breathing directly with a nasal flow sensor and effort belt, as well as oxygen levels and heart rate on the finger sensor. And so it's able to detect drops in airflow paired with drops in oxygen levels and score sleep apnea events that way. But as you can imagine, some of those sensors do fall off sometimes for our patients and can be less accurate. And so that can be a downside to this this testing modality. And in addition, it only tests for sleep apnea, so there's no other sleep parameters involved. Putting those two together, broadly speaking, home sleep tests are easy and done at home and cost-effective, but they only test for sleep apnea, and they may miss or underestimate sleep apnea because, as we noted, the sensors can fall off. And I forgot to mention, if a patient spends many hours that night not sleeping, we'll capture a lot of awake breathing, which will look normal and thereby dilute the results of the test. And then the polysomnogram, on the other hand, highly accurate, it's supervised. You can test for a variety of diagnoses. It can be a challenge to sleep in the sleep lab, and obviously it's expensive. It can be an opportunity for us to test CPAP out with the CPAP titration study, which we'll talk a little bit more about later. And really importantly, another way to think about this is how it relates to our patients. So this slide is really important. Home sleep tests are ideal for diagnosing sleep apnea in patients with high pretest probability, where even if the sensors fall off and even if they don't sleep well, most likely we're going to catch it. And maybe it's a good test for someone who's overall a really low risk patient. But it's really the polysomnogram that's ideal for patients that have a low pretest probability. Maybe we aren't quite sure what's going on. And it's essential for patients that are high risk. If they have comorbid heart or lung disease or require oxygen at night, we want to make sure we monitor that patient carefully overnight, and we want to get the most accurate information that we can. In addition, we may need that polysomnogram to diagnose other sleep disorders. So really important. And just to drive it home, we're going to do a couple of cases, and folks in the room can maybe shout out the answer. So case one is a 52-year-old male with a history of hypertension and migraines. Wife elbows him to turn over at night due to snoring, dozes off easily during the day, has a BMI of 32 and a Mallampati 3. What is the most appropriate test for this patient? We've got B, home sleep test. That is correct. So this patient is overall pretty low risk, and they have a high pretest probability. That stop bang score is pretty high, but they're otherwise fairly young and healthy. So that is correct. Next case, 72-year-old female with a history of AFib and COPD requiring 2 liters oxygen at night, denies snoring, daytime sleepiness, does not think she has sleep apnea, but she does wake up short of breath on occasion and gets up frequently to urinate during the night. Her BMI is 22. What is the ideal test for this patient? We've got A or C. The answer is C. So this is a patient who's relatively high risk. She's older, she has AFib, and she's using oxygen at night. She has lung disease. So we want to make sure in her case that we get a really accurate look and in a supervised setting. If we were to do a home sleep test, we'd have to take her off of oxygen to do it, and that might not be safe. So we want to bring her in. In addition, it's not quite clear she has sleep apnea. Her symptoms are pretty nonspecific, and so we want to be able to evaluate for maybe other sleep disorders and make sure we have an accurate look. The reason why we choose a split night over a diagnostic, essentially in adults, we always want to choose a split night over a diagnostic in most cases because it gives us an opportunity to try CPAP during the study. And that's often a crucial piece to treating that patient and making sure their treatment's effective. All right, good job on the questions. I want to start talking about the other choices that we have now for home sleep testing, which it's nice that we have them. And I'm going to start with the WatchPat. So many of you are ordering WatchPat studies a lot, but you might not know how they work or how they perform. So WatchPat calculates respiratory events indirectly using peripheral arterial tone in the fingertip. So it detects these episodic rises in sympathetic tone throughout the night, during which the PAT signal narrows, oxygen levels drop, and heart rate increases. And that captures the event during the night. We, again, add up all those events and divide by the number of hours of sleep, and we can get an apnea-hypopnea index. So it's an indirect measurement. This is what the test looks like. It's a wristwatch type of device with a finger sensor. It's pretty easy to put on. What's really nice is it's disposable, so our patients don't have to make an appointment to come back to return the device, which is really, really helpful. They're pretty affordable too. I forgot to mention home sleep tests are usually in the matter of hundreds of dollars instead of thousands, and WatchPat is one of the cheaper ones. It does require a smartphone, so it's something to think about with some of your older patients or those who are not good with technology. So you might be wondering, how does WatchPat perform compared to polysomnogram? And hopefully you can see it okay in the table here, but essentially the more severe the sleep apnea gets, the less sensitive the test is. And when the sleep apnea is really mild, it's not very specific. So there are some limitations. There's also limitations in that we don't have a lot of testing at high altitude, so that can be a problem here. Cardiac arrhythmias and pacemakers, as you can imagine, we can't quite always capture that heart rate response in patients with those conditions. AFib, for example, has a much lower yield with WatchPat, so I would avoid WatchPat in your patients with arrhythmias. And then things like alpha blockers and poor circulation in the fingertip can be barriers. So going back to our cases, this would be a fabulous test for patient one who had a pretty high pretest probability. It's likely we're going to catch sleep apnea. And it would be a very bad test for patient two since she has AFib. And we want to make sure we get the most accurate assessment. It is wasteful. Yes. Yeah. Yeah. They aren't reusable. They're thrown away.
Like, what is it? It doesn't make sense to me that the more events you have, the less sensitive the test is. Like, why? What does it just not pick up all of them, or that's just it's dichotomous? If you have a lot of events, it's not going to diagnose you with sleep apnea.
When there's many, many strings of events in a row, the algorithm starts to have issues. So yeah, it's kind of on a technical basis. Good questions. Another test that we, sorry, yep. Mm-hmm. It might be more that, so I don't know the exact answer to this, but I would suspect that instead of diagnosing 90 events per hour in a really severe case, it might diagnose 70. So it's not going to be necessarily able to detect all of them. Right, right. Which is why I think it's a good test in those patients with that are low risk with high pretest probability. Yep. The next test we're going to talk about is called sleep image. We do have this test at our facility, but most people don't know about it. It's actually a small little sensor that goes on the finger, like a ring. So it's very, very easy to use. It also requires a smartphone and an app. And it uses, similar to WatchPat, it uses an algorithm to indirectly measure sleep apnea events. It's a proprietary algorithm. I don't know how exactly it works, but it does have really good correlation with sleep apnea by PSG. It also gives us some information on autonomic tone during the night, so things like heart rate variability. And it can give us a sense of sleep quality and degree of sleep fragmentation in our patients with insomnia. It is being used a lot in the dentistry community, which makes me a little bit nervous. I think this is a test that requires some nuance to reading and interpreting. The technology is called cardiopulmonary coupling, or CPC, but we mainly refer to it as sleep image. In my experience, the worse the sleep quality gets, the less specific it becomes, and can't really tell if oxygen's dropping a bunch during the night because of sleep disruption or because of sleep apnea. But I just want you to know about it because we do have it here, and you might see these reports in some of your patients' charts. Aside from the WatchPat and the sleep image, we aren't seeing a lot of other devices enter mainstream sleep medicine practice, but people are coming out with new gadgets every day. The new technologies seem to be either aimed at combining various modalities of testing, maybe respiratory with EEG, to try to get more accurate data and more closely approximate the gold standard polysomnogram. And then other tests are really aimed at advancing their technological algorithms for indirectly detecting sleep apnea and getting smaller and smaller. Most of these, as I said, are not widely used. They're still being mainly marketed towards research, and some of them are FDA approved and some are not yet. So speaking of FDA approval, I wanted to make sure we took a moment to talk about consumer wearables, which have, as you've probably seen, sleep wearables have really entered the health and wellness scene and are taking over our clinics. These devices have proprietary algorithms with very little publicized validation data. And the bottom line, that means we just don't know how well they perform. We do have experts in the community who speculate that the Apple Watch, for example, is about 60% sensitive for detecting sleep apnea. But again, we don't truly know. We are happy, though, that overall we think this is a good thing in sleep medicine. It's bringing people through the door, it's raising awareness of sleep disorders and sleep apnea altogether. Let's shift now towards treatment of sleep apnea. Yep.
So when we pull up the wizard and just order an in-home sleep study, it doesn't ask us to choose among those. Is there, like, what happens after we place the order, and is it they're given one of those three, or like how does that work?
Yeah, there's 2 different home sleep test orders. I don't know how it looks to all of you. We can look at maybe the Epic window after this and I can show you. But there's the flow-based home sleep test, that first one I showed you, the traditional home sleep test, and it has a code, 95806. All the other sleep studies would fall under a different code. Some people seem to be knowing how to order them. I think it says WatchPat in the title. You'll automatically get WatchPat unless you specify that you want sleep image. Yeah.
Rephrase that just a little bit to confirm. So we can actually order WatchPat or CPC here?
Mm-hmm. That is correct. Yes. All right. So going on to treatment, I'm proud to say that the number of treatment categories for sleep apnea is finally growing. It's been constrained to CPAP for a really long time, but let's talk through all of them. We'll start with the tried and true continuous positive airway pressure, or CPAP. So for a little reminder, CPAP is a mask worn on the nose or the mouth that blows air pressure into the airway. It acts as a splint to prevent the airway from collapsing. It continues to be first-line therapy. So any patient that comes through the door, unless they tell you there's absolutely no way I'm trying a CPAP, that should be the first thing that we reach for. It is the most effective and it's non-invasive. It can work at any level of airway collapse. And it's the most economical. It's covered by almost all insurances. If the patient takes it home and hates it, they can give it back. That's another advantage that I mentioned to patients. Unfortunately, CPAP still gets a bad rep these days. Most patients picture a Darth Vader style mask and a big noisy ventilator type of machine. But the truth is, CPAP has improved a lot. There are dozens of mask options. It's gotten so much better. The masks are really well engineered now. They're much more minimalist and flexible and soft. They've recently incorporated memory foam. And there's companion apps for the devices that help with adherence. There's instructional videos on the app, really fine-tuning of humidity and temperature. And the machine itself is quiet and light and portable, all of that at a very reasonable cost. The therapy features for CPAP haven't changed too much over the last 5 to 10 years. There's different modes that we can prescribe. We can actually make pressure changes via the internet that go to the patient's machine, and we can read their numbers remotely as well. Therapy reports continue to give us things like leak usage and residual AHI, which tells us how the patient's CPAP treatment is doing. So overall, it's really well integrated with our clinic. It's important to keep in mind any patient who is struggling to tolerate CPAP despite all the improvements that we've seen with comfort really should undergo an in-laboratory CPAP titration before they give up. The reasons being, we can identify problems that are keeping the patient from being able to sleep well with the device. We can identify optimal PAP settings, make sure their mask is fitting them correctly and it's placed correctly on their face. So lots of patient education opportunity, and we can look for other sleep disturbances that might be interfering with the treatment. Things like treatment emergent central sleep apnea as well, particularly here in Colorado. So a really good idea to go ahead and order this study when your patient's not doing well on CPAP. I want to take a moment to acknowledge that while CPAP is known to be the most effective treatment modality for sleep apnea, daytime sleepiness, and quality of life, other measurements of CPAP efficacy have unfortunately fallen short of expectations when it comes to the medical literature. One of the main reasons for this is poor adherence. So across most of our research studies, adherence averages 3 to 4 hours a night. So that's half the night. That's kind of like doing a study where the participants take their medicine every other day, and then we measure the effect. It's not really an accurate look at what CPAP can do when it's worn for the full night. So that might be a reason why we're missing a lot of the improvements that anecdotally we tend to see in clinics, such as improvements in blood pressure, cardiovascular events. And we know small studies have shown improvements in mortality and motor vehicle accidents as well. Oh, looks like I need to migrate my mouse over. Let's see. Oh, no, I still don't have it. All right, very good. Thank you. So still the problem with CPAP is that adherence. Adherence is directly proportional to effectiveness. So more hours equals more improvement, but adherence is poor. And so we have difficulty establishing treatment efficacy and giving our patients the full benefit. Recent studies show that adherence may be improving, but until then, until we can improve what's happening, we're kind of stuck when it comes to CPAP. Next, we'll talk about oral appliance therapy. How many people prescribe oral appliance for sleep apnea? Anyone? Okay, a few of you. So it is a little bit tricky. To go over what it is, an oral appliance for sleep apnea is like a retainer that you wear when you sleep at night. It shifts the lower jaw or mandible upward or forward while you sleep to help open up the posterior airway. And it is fitted and adjusted by a specialized sleep dentist. Yes, those exist. The overall success rate for oral appliances is 60 to 70% in the literature. And I'll just make a note here, in sleep apnea literature, success is defined by at least a 50% reduction in the AHI. So it does not mean cure, but at least a 50% reduction, which means patients with really severe sleep apnea who might improve their AHI from 40 to 20 aren't really seeing a full treatment benefit. So this treatment is better in patients with milder sleep apnea. We also see it perform better in patients that are thin. You must have teeth to be able to wear it. And as far as adverse effects, we see mainly issues with jaw pain or discomfort, sometimes tooth pain or headaches. But overall, patients do like these, and adherence can be better because there's nothing on the face that the patient has to get used to. They are expensive, very expensive. And what's important is they're covered by medical insurance, not dental. So if you want to refer your patient for an oral appliance, you need to put together a referral packet and send that to a certified sleep dentist. We don't recommend using general dentists. The patient's own dentist won't be able to bill medical insurance and won't have the training that's necessary to make sure the device is successful. Very importantly, it is not covered by Medicaid. And then I want you to beware that there are other dental practices out there that in the community that are really can be harmful and are not effective, but there are sleep centers, dental sleep centers, and other predatory practices that really prey on patients and offer them these procedures when they really can cause a lot of harm. So if your patient is considering one of these, I would strongly discourage it. Yeah, I'm glad you asked. The over-the-counter appliances are not as effective, and they're a lot less comfortable, so we don't see good adherence for them. But I have the occasional patient who does have success with it. The sleep dentists hate them, but there's reasons for that probably. So surgical treatments for OSA have improved a lot, and we're going to talk about Inspire, the hypoglossal nerve stimulator. When it comes to surgeries for sleep apnea, there are many, many different surgical approaches that target the upper airway, as you can see here. However, what's really important to know is that most patients are in fact not good candidates for surgery. There's really only 3 main categories that we think about doing surgery for sleep apnea. The first is to improve CPAP comfort or adherence. So that might be with a nasal or sinus surgery to make CPAP mask more comfortable. The second category would be if we see an obvious point of obstruction like huge tonsils in the back of the throat. We do a tonsillectomy, might be curative. But most patients fall into the third category, in which we will try CPAP and or oral appliance therapy first before even considering doing surgery on a patient. And that is because CPAP is, as we said, the most effective treatment, and it's non-invasive, whereas surgery is invasive and it's a lot less effective. In recent years, most surgeons are turning to a procedure called a DICE. Has anyone heard of drug-induced sleep endoscopy? So it's essentially where we do an endoscopy while the patient is sleeping to see where their obstruction is occurring. What we've seen is this can improve treatment outcomes a lot because it can help us identify the exact site of obstruction and give the patient a better chance of success with surgical interventions. And so we are doing a lot of these at our center. And then procedures have also become a lot less invasive and more effective over the years. You might be familiar with the old UPPP, where everything gets cut out, doesn't perform very well, only about 40% success rate, whereas nowadays, things that are minimally invasive, like a pharyngoplasty, have a lot better success and really focus on repositioning and stiffening rather than resecting and relocating. And they have much better recovery and are better tolerated, as you can imagine. But it's really the Inspire implant that has really taken off over the last 5 to 10 years. Many of your patients are probably asking about it. And essentially, Inspire is an implanted airway pacemaker. It is the same size and shape as a pacemaker. It goes on the chest, under the skin, just like a cardiac pacemaker. What it does is it has a lead that goes into the neck that stimulates the hypoglossal nerve during inspiration. That contracts the genioglossus muscle and causes anterior movement of the tongue and the anterior pharyngeal wall. So it brings everything forward with each breath. So it's a single incision with multi-level effects and minimal recovery time, which makes it ideal for surgical candidates. But it's important to know that most patients are not candidates for Inspire, and we'll go through some of these. First of all, most of our patients with sleep apnea are obese, and a BMI cutoff of 32 is pretty hard to achieve. There have been leniency measures. The FDA has granted it up to 40 now, but our surgeons don't agree. They find that going up above 32 really reduces the efficacy. Other things would be the OSA severity. It has to be at least moderate or severe sleep apnea. And we do have to see a tried and true trial of CPAP and failure of CPAP tolerance. And then things like no central or mixed sleep apnea, the device doesn't treat that. They have to have appropriate airway anatomy on DICE. And then they need to be a healthy surgical candidate. So we're not going to be taking, unfortunately, the 85-year-old with severe sleep apnea who has a bunch of heart conditions. But we do get that question a lot. And you're likely wondering, how does Inspire perform compared to other treatment options? So it first came out with a trial in 2016 where the median AHI improved from 28 to 8 with an overall success rate of 74%. So it does perform pretty well in certain populations. And we're seeing this number maintain with our registry of patients. So of all the surgeries that we can perform, this is definitely the best one that we have. And there's more stimulators on the horizon, but I won't go into that. This is just a peek at one that's coming to UC Health soon. And of course, bariatric surgery, let's not forget, is a very effective means of treating sleep apnea. But I wanted to remind everyone, make sure you document remission of sleep apnea before discontinuing CPAP, because it does not always go away. Next, we'll talk about OSA gadgets. So these are things that they don't work very well, and they're not covered by insurance, but patients like to ask about them. So I thought you should probably know. One is called the iNap. It is an intraoral negative pressure device. It's a device that sits on the tongue and suctions it forward while you sleep. Sounds very bizarre, and it is, but it has some pretty good data in mild sleep apnea. And unfortunately, it's not covered by insurance, and it's a couple $1,000 plus refills. Same with the Excite OSA device. This one is an external neuromuscular stimulator. It's a device that clicks around the tongue, and it stimulates the tongue muscle during the day. You wear it for 20 minutes a day, and it strengthens the upper airway to prevent airway collapsibility. It is, funny thing, being really well sponsored by the VA, and so patients at the VA can get this, and it can help with mild sleep apnea and sleep apnea symptoms marginally. There's other gadgets like positional devices. There's a device up here that buzzes when you turn to your back, and there's a bump devices like big hard pillows that go behind the back to prevent you from turning over, and those are really only effective in positional sleep apnea. There's nasal gadgets, which can help open up the nasal passages. Those can be modestly effective and can help with snoring, certainly. And then there's mouth taping. I'll just take a second to talk about mouth taping because it's become very, very popular on social media, for example. The idea is that mouth breathing is associated with increased airway resistance and pharyngeal collapsibility, and that maybe closing the mouth, we can increase inspiratory airflow in patients with OSA. However, there's essentially almost no data to support this. The best study that we have is from JAMA Otolaryngology in 2024. It's only 54 patients, and they observed them sleeping and saw that their inspiratory flow did improve by 25% with jaw thrust. But what's important to know is that some of the cases where sleep apnea was really severe, the airflow got worse with that jaw thrust, which means that our patients who are at the highest risk can get worse sleep apnea when they mouth tape. And so at this point in time, the American Academy of Sleep Medicine strongly recommends against mouth tape for sleep apnea. The only time that we really use it is in patients who are wearing a CPAP mask and need some assistance with keeping the mouth closed while they wear it, which is still safe because they're actually getting airflow. And then lastly, we'll go through medications for sleep apnea, which is a brand new category. Yay. We've got two main categories of medication for sleep apnea. The first is weight loss medications, and you are likely all familiar with tirzepatide. It's currently the only medication that's approved for OSA, with its first groundbreaking study in the New England Journal in 2024. The trial was called the SURMOUNT-OSA trial, and essentially it showed a 25-point reduction in AHI in patients with obesity and OSA. The mean AHI was 51, and the mean BMI was 38 to start. So very successful treatment, very severe cases to begin with. And you all know the insurance barriers that exist. The new category of medications I want to make sure we touch on are airway modulators. So many of you have probably not heard of this yet, but our patients are bringing this to our attention in sleep clinic. There's a new drug that's being tested. It's called Apnea, and it's a combination pill of atomoxetine or Strattera and eroxybutynin, which is an R enantiomer of oxybutynin. And the combination has been shown to help with mild sleep apnea. It came into the news recently when it got its FDA fast track designation, and we think it'll be approved by 2027. So these two meds, when taken together and separately, can improve mild cases of sleep apnea. So patients read about this, got really excited that there's a new pill for sleep apnea, but I would certainly tame your excitement level because these are modest improvements in sleep apnea severity. And in addition, there are pretty significant side effects with these two agents. As you can imagine, taking Strattera at bedtime is not a great combination. And so insomnia has been a big issue, and we haven't yet seen that this med can improve any symptoms. So it can improve numbers, but the patient doesn't feel better, and that's a problem. We'll see where this goes. It's in phase 3 trials right now, but before you know it, people are going to be bringing this to your attention. So I want to make sure you know about it. And then lastly, just want to put out there, the future of sleep medicine really lies in getting a better understanding of what it is that we're missing. We know that we have important gaps in OSA knowledge that we still need to fill, and we don't fully understand things like why do some patients with sleep apnea have daytime sleepiness and others do not? Why do some patients get heart disease and others don't? Why do some patients respond well to CPAP or surgery and others do not? So we don't really fully understand all the missing pieces. One theory is that maybe the AHI is not the best measurement of OSA severity. So there are some brilliant minds out there working on trying to identify better markers, such as hypoxic burden, which you see on the right there. It's the area under the curve, essentially, with sleep apnea events. And already we've seen that hypoxic burden can have a greater association with adverse cardiac events compared to AHI. So we might be onto something there. Or perhaps we need to do a better job of phenotyping our patients based on the physiologic mechanism that we believe is responsible for their sleep apnea. There's many different mechanisms involved with airway collapse at night during sleep. And once we get a better understanding of that, we could better tailor our treatment. But until then, we've gone through basically all of the treatment options, and we know that there could be more on the way as long as we could get a better understanding of this. And that's where we'll finish. So thank you very much.
Well, we have a lot of
A
questions.
lot of questions. Okay.
So we'll start with the chat. And this is a two-parter. For mild sleep apnea, is CPAP first line? And then the second part is, does the severity of sleep apnea matter when recommending one treatment or another?
Yes, great question. CPAP is first line for any degree of sleep apnea, mild, moderate, or severe. A trial of CPAP is always recommended. However, if your patient has mild sleep apnea, they may do relatively well with an oral appliance because it can do a good job at treating those mild cases, especially if it's a thin patient.
Speaking of oral appliances, do we have those specialized dentists here that we can refer to here?
I have a list. So if you want to email me or secure chat me, I can share my list with you. Actually, I think it might be universal now. Sleep dentist, I want to say. Sleep dentist.
We'll check sleep dentist.
Yeah, but you want to use our list.
And then another question from the chat, in terms of knowing the treatment is efficacious, how do we know that based on the AHI? I think I saw it on your slide, and this is new for me. Is it that patients have to have both a 50% reduction in their baseline AHI and have that be below an absolute number of 20?
No, that's what the studies use to define success. In clinical practice, we essentially want to eliminate sleep apnea. So we want the AHI to be below 5, whether that's a CPAP download showing an AHI below 5 on treatment or follow-up testing of an oral appliance that shows we've improved it to less than 5.
There's a whole range of questions on insurance, and I'll actually start with my own. So for testing like WatchPat or CPC, how often does insurance cover positive airway pressure based on the results of that testing?
It really comes down to the AASM definition of sleep apnea. So if the AHI is above 15, you don't need any comorbidities to be documented. If the AHI is less than 15, so it's in the mild category, you do need an associated comorbid condition or symptom. And then I had a feeling you guys would ask about insurance, so I do have a couple of slides on that that you can read while we answer questions, maybe.
And another insurance question was the DICE, the drug-induced sleep endoscopy. Is that something that insurance coverage is good for? There's trouble for? Like, what's that like?
It's variable, but your sleep surgeon will do all of the work on that. So that's nothing for you to worry about. When we refer our patients for a sleep surgery, it's really the surgeon who will decide and make those arrangements for DICE if they feel the patient is a good candidate. Yes.
If you've got somebody on CPAP and you want to document effectiveness, and you want to order a follow-up test, do you order just a polysomnic nighttime pulse ox, or do you order another sleep study with them on CPAP?
The easiest way to tell if CPAP is effective is to acquire a download of the patient's data. You can request that from the DME company who is supplying the CPAP with a general DME order. And the patient can also show you that actually nowadays on their app. So they can pull up their app and show their event numbers, which is their AHI. And so you can see on a weekly, monthly basis how they're doing. You can also, if the numbers look good, for example, and the patient doesn't feel good, I wouldn't trust the numbers. I would say it's time to go get a sleep study. We would do an in-laboratory CPAP titration. Another way of approaching it could be to do a WatchPat study on CPAP. So we do that a lot now. The WatchPat can be worn while the patient wears the CPAP, and you can get a sample of their AHI on treatment. It often lines up pretty well with the download from the machine, but not always. But you just have to know that if it does look like it's not controlled, you're going to want a CPAP titration anyway. So be mindful of, do I really need this test?
So my question relates to phenotype, but in terms of responses. So like my experience is there are like three categories. They're the ones who wake up the next morning and say, I've never slept so well in my life and I feel so great. And they will never go a minute without it if they can avoid it. At the other end are, 20% to a third who are like totally allergic to it and they say they can't sleep. And in between, there's sort of this persuadable group who will use it because it's good for them, but they don't really perceive that they feel any better. Their life, it's inconvenient or whatever. So I'm curious, does that bear out in the literature or your practice? And second, do you have any, like, how do you deal with the folks for whom it requires more persuasion or that they're really have difficulty with it?
Right. So yes, that does bear out in the literature and in my experiences. I think that in the sleep clinic, we have probably a lot better success than the literature because we have a robust set of resources for the patient and do a lot of counseling. And so if a patient is not feeling better, if they're in that middle category where we know that we might be able to get this right for them and they might just maybe they'll still use it just because they have to, but they don't love it. We'll take those patients to the sleep lab, make sure that all the PAP settings are looking good. We'll do mask fittings. I think that would be an appropriate referral to sleep. If your patient loves their CPAP and it works wonderful for them, you probably don't have to do anything else. But if they're in the other categories, we can certainly help them, and we have a lot we can do.
First 3 weeks, you roll it down. Is that a thing?
Yeah, people have really gotten away from that. I don't know anyone who does it anymore. It's just not as safe and ideal, and we have better, I think, understanding of acclimation strategies too, helping the patients get used to the mask, and the masks have gotten a lot better. So,
Can you tell us more about those acclimation strategies so we can counsel
Oh.
patients on that?
So really, we have patients come up with a routine where they start with daytime practice and they gradually build up their daytime exposure to the CPAP. They wear it during the day while watching TV or doing dishes, and then they wear it while it's plugged in and turned on. Before they even try to sleep with it, we've got to get them comfortable while awake. And then once they are in the bed, then they try it for 5 minutes and then 10 minutes and then 30 minutes and so on. And we create kind of a schedule for them.
And then the last question for today, you're trying to figure out the right patients to send for referral because there's a lot of these things we do in primary care, but who's the right patient or groups of patients for us to refer off to be seen in sleep medicine?
Yep, we're happy to see anyone. Sometimes it'll be a patient that's really resistant to the idea of sleep apnea or treatment and really needs a lot of counseling. Sometimes it's a matter of complexity, medical complexity, or the complexity of the sleep apnea itself. You might get a report that looks really confusing. There's central sleep apnea and mixed sleep apnea, and I don't really know what ASV is. So we're definitely happy to take and manage those patients. And then if CPAP is started and it's just not going well, we're happy to take those patients.
So thank you so much for joining us today and giving us, it was an extremely helpful update. So thank you.
My pleasure. Thanks for having me.